Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very excited today to be talking with Christine Bechtel, who is a patient advocate and co-founder of X for Health, a purpose-driven organization on a mission to make healthcare better for all people. She works with a group called X4 that organizes the third conversation, which is what we'll be talking about today. Christine, thanks so much for joining.
Thanks for having me, Larry. It's great to be with you.
So I suspect people aren't familiar with the third conversation. Could you tell us about it?
Sure. Third Conversation is a national initiative that started with the realization that we were having what felt like two separate conversations in our healthcare system in the United States. One is the conversation we hear a lot from patients and families who talk about how frustrating the healthcare system can be, how hard it can be to navigate, and how challenged it is to get enough time with their doctors and nurses. And then we were hearing a second conversation, largely among health professionals, about burnout and well-being, and how challenging it was for them to work within the system. More than half of primary care clinicians showing signs of burnout, increasing numbers of clinicians feeling depression, and even 10% having suicidal thoughts. And when we stepped back, we really asked ourselves, first of all, what the heck is going on? And second of all, we put it together that these two sides of the coin, patients and clinicians, are working in the same healthcare system. And it's really the same properties of the system that are causing burnout issues for clinicians and dissatisfaction and frustration for patients. So we really wanted to bring them together and find out what would happen if they got into a room together for 3 hours, in the evening with a professional facilitator and started talking, being vulnerable with each other and sharing what the healthcare system really looks and feels like from their perspective in a way that they really hadn't done before. So the third conversation is just that. It is bridging those two conversations together in communities across the country. We've been in 10 communities so far, in an effort to really pull back the curtain on what's happening in healthcare.
So what are the key insights that you've learned from being in these 10 communities?
We've learned a lot. I'll say first that we were really inspired by the science of empathy and this idea that if you can create an empathic connection between two human beings, and you can create that light bulb moment where one of them says, oh my gosh, I had no idea that this is what it was like for you, we've got to do something. They almost always get to that point of we've got to do something. And so third conversation, a big part of the theory of change was, could we spark those moments of bidirectional empathy, and would they lead to bigger changes together? So we were inspired by the work of Brené Brown. We were inspired by complexity theory, narrative leadership, design thinking, and appreciative inquiry. So third conversation rolls these concepts into one. Some of the things that we've learned by observing these conversations firsthand, number one, the system has a subtle way of setting up patients and clinicians more as adversaries than allies. This was surprising to us in the beginning. We realized, for example, that patients want more time with their doctors and nurses, but because of our payment system and all the reasons we know, they don't have time to give us. And it sets up these sneaky little tensions. And it's not the fault of patients or clinicians. It's really a poorly designed system of healthcare that incentivizes and has a big business component, fee for service, et cetera. So for the first recognition that we needed to recognize that this adversarial relationship exists and it's not our fault, that was really important for us. And when we started to unpack that, we also learned that patients and clinicians have a lot to learn about each other. First of all, I think a lot of us think we know a lot about patients, but it turns out we've seen over and over again that there are a lot of assumptions that have been made that are inaccurate. I remember one event in Third Conversation where a provider stood up and said, "Oh my gosh, I thought this whole time that my patients were like hiding things from me in the visit. And it turns out they're not, they're filtering. They are in real time recognizing that I'm coming into the room with my hair on fire. I'm so busy. I'm overwhelmed. I'm late. Everything I'm telegraphing is impatience, and they're trying to filter. I misinterpreted that. I thought they were like hiding things from me, not giving me the full picture." That's really important. And it spoke to that adversarial sort of relationship. It's a system design problem. I've also heard clinicians say, "I didn't realize that patients don't expect me to be perfect." Like, that's huge for them to recognize that. By the same token, patients have said in these events, "Oh my gosh, like I didn't know all of the things that my doctor has to do on a daily basis. I didn't know that they don't, know the cost of medications they prescribe. I just guess I didn't realize how much healthcare really is a business today." Those critical insights show us that we still have a lot to learn about each other. And I think that leads to our third big insight, which is just how important relationships really are in healthcare. For us, what we've seen is they're both fulfilling in and of themselves, and they're facilitating. So they're like a means and an end. So for health professionals, I think they help facilitate better health outcomes for patients. That relationship is a channel for gathering, information, particularly in primary care, about the full picture of a person's life, and that relationship being built around trust and open communication. But they also are fulfilling for healthcare professionals in and of themselves and help to address burnout, again, particularly in primary care. So those relationship components are huge. But for decades, we've really spent more time focusing on transactional, kind of the structural and the technical, like the what and the how of healthcare, instead of the who and the why. And what we're learning in these events is that it turns out that when it comes to the who and the why, and even the what and the how, patients and clinicians want the same things. They want exactly the same things. They want more time together. They want more connectedness. They want less focus on documentation and computer screens. We had one patient said, "I want more hugs," and all the healthcare providers in the room started clapping. The last thing I'll say is, I think also we've learned that we're generating a new kind of human connection that is fueling a truly different conversation. And because of that, we think we're going to need to have leaders in the room. So these conversations to date have been largely focused on patient and clinician relationships, but our partners at the healthcare system level, who really can shape and influence decisions every day, they need to be in the rooms too.
So I'm fascinated by what you're saying. I have for years heard about and talked about the difference between transactional care and relational care that integrates relationship into the care delivery process, and that what would you call it, bubble happens during the encounter and around the encounter. But for people who are outside of that clinician-patient environment, everything's transactional, because the only way that a health system or an insurance company really makes money is if those encounters take place and they generate so many RVUs or so many points that translate into dollars. So that the tension between that bubble that needs to protect relational care and the larger enterprise of making money seems to have inherent conflicts.
I agree. And I think I would also point out that the relational quality is in a transactional system is often thought of as one way. It is the doctor-patient or clinician-patient relationship, which is really a vessel for the clinician to provide care to the patient. the big insight and the aha moment of Third Conversation is the recognition of how personally and professionally fulfilling it is for the clinicians to be in relationship with their patients, number one. And number two, that there's an opportunity to enable those relationships to happen outside what you just described as the bubble of healthcare. They because we live in a transactional system, those relationships happen in visits and encounters. But when we're bringing people together, it is in the evening or the late afternoon,
Right.
It is over a meal. And that, even that short 3-hour opportunity is so rewarding for clinicians. And I could talk about some of our evaluation data. I mean, they tell us that the sense of relief that they feel walking out of that room is profound. They're like, I can't believe this, I feel so much better in just, 3 hours, being able to really share who I am, why I do what I do with another human being who gets it is so critical. We had, it was in this case, a physician stand up and say, this was in Northern California. She said, I have never felt so genuinely cared about as a doc. And that meant so much to her. We also, hear the clinicians, in our evaluation data, about 75% of them agree that Third Conversation can help address their feelings of burnout. And about 25% of them say, they're not so sure or they disagree because the factors that drive burnout are multifaceted. So this is definitely not a panacea, but even the sort of almost therapeutic quality of this has been really helpful for the clinicians. And the last thing I'll say from our evaluation data that I feel like is super important is about 8 in 10 of everybody who has participated, whether patient or clinician, tells us that they leave the room feeling more hopeful about the healthcare system and about their ability to impact it. And what we know about creating movements for change is that they have 2 really essential ingredients: hope and agency. So being able to feel more hopeful and like you can really make an impact is such a critical component. And that's just for one conversation.
Wow, that is very powerful. The thing that strikes me, Christine, is that in the healthcare industry, the consumer's voice, other than being off in a corner, whether they're writing articles in newspapers or having what you call the first conversations outside, the consumer's voice is not part of the design process. And I think, at least what I'm hearing, one of the implications is using the Third Conversation, you're able to bring them into contact with the clinicians, and together their voices perhaps can influence change that needs to happen. Could you comment on that?
Oh boy, did you ask my favorite question, Larry. Thank you. Yes, that is one of the things that's so inspiring about Third Conversation. And it's also true that we have a long and rich history in this country of designing things for patients, but not with patients. And
Right.
that has led to some really expensive and really costly mistakes, like the way we designed the role of primary care as gatekeepers in the HMO days. Nobody asked patients. I'm pretty sure nobody asked primary care doctors either. And we ended up with a major consumer backlash in this country. So I think I'm not sure we've learned our lesson. Here we are in an environment with COVID where there will be, in my view, a giant reckoning about how we finance and organize healthcare in the United States. And if we're learning anything from Third Conversation, it is that the nature of the solutions that emerge when 2 human beings who have 2 different roles in the same system, patient, clinician, when they are able to deeply connect as people, when they can hear each other in a new way, when they can feel understood and get real and vulnerable about what the system looks like, and also call forth those MVP moments in healthcare when they've had great experiences, use a little design thinking, design around them. When we do that kind of an approach, the nature of the solutions that emerge are fundamentally a lot more innovative because patients come from a different perspective, they're much more easily challenging of the status quo because they don't really recognize what the status quo is or why the system has to be the way it is. So those solutions that are designed collaboratively with patients and clinicians, we're seeing a lot more innovation potential that's emerging. So huge hopes that as a country, we'll be able to roll this up into the national level where our national conversations in the advocacy world have often been zero-sum, blame and shame, super transactional. But again, if we're deeply listening, we're accessing a much deeper part of ourselves, we're designing around MVP moments, it really generates an inspired and collaborative leadership where it's like power with instead of power over. That model is so much more effective for building the healthcare system we all want, particularly post-COVID.
So I'm wondering if you could comment on, we are in a very slow and uneven transition from a fee-for-service to a value-based payment. People haven't quite figured out what value-based payment, but there's a general move in that direction. And I'm wondering if you could comment on the implications of what you're learning for value-based care delivery at the primary care level and at the health system level.
I have personal opinions on that. The tricky thing when we explain to people what third conversation is that third conversation does not walk in the door with an agenda like we have to upend value-based care or we have to go to capitation or we have to do X, Y, or Z. Because we've been in a transactional system so long, the instinct that most people have, patients and clinicians alike, is to get right to the doing. But we've skipped over the being part for a long time. So third conversation right now, the first event that we do, which we call a spark event, because it sparks a new mindset shift in people and a new awareness of the importance of human connection, is actually agnostic to payment systems or electronic health records. Those issues absolutely come up. But it's not the insight that I have is not generated by third conversation yet. I think one of the challenges we face is figuring out how to support these community groups in moving out of being and towards doing, but still doing that in a way that preserves their bond, their human connection, and their relationship. So I digress. I do think my own personal opinion is that most of the value-based care models that we have are still built on a fee-for-service chassis. And until we address that fundamentally, and probably consider creating a payment system that is specific to primary care rather than a one-size-fits-all payment system that is fee-for-service for everyone, whether you're a hospital, a nursing home, or a primary care practice, or a minute clinic, that doesn't make sense to me. So I think we probably have to think about that in a different paradigm.
Okay. So what's next for Presea?
Really good question. Obviously, COVID brings a whole new context for us. There was a wedge in the doctor-patient, clinician-patient relationship before COVID. Now we've got more isolation. Primary care is in deep trouble financially. We've got 10% of practices have already closed. More say they can't, like 40% can't see a financial future for themselves 4 weeks from now. So first we have to make sure that primary care stays open for us. That's really important. We're doing a lot of work on that. When we get past the initial instability and shock of COVID, third conversation is redesigning our programming to be part of the recovery process. Our sense is that people will need a place to reconnect, to reset a little bit, and to start new conversations that can be transformative for ourselves, for our relationships, and for the systems where the healing takes place. We feel like there's a need to have a forum for exploring, for processing what just happened. What did we change? We are making massive overnight changes to the healthcare system. Telemedicine, pay parities, like all these different changes we're making. What of those changes do we want to keep? And what did we learn collectively about what really mattered? So we're designing our programming to be a place to fuel and support a recovery process, to really have a new conversation, a fresh conversation about what we want relationships and the relational quality of healthcare to look like. We're developing virtual programs as well. It's a huge challenge to figure out, how do we facilitate human connection virtually? Fortunately, we have a lot of experience doing that, so we're hopeful that between Zoom and now patients using telemedicine, we're going to have an easier time of that. And then the other thing is, our deep belief that we cannot process what do we want to keep, what really mattered with only patients and clinicians in the room. We have to have our local healthcare system leaders, CEOs, healthcare administrators, chief medical officers. That conversation is really important. And I want to be really clear. We did interviews with about a dozen system leaders around the country. And I can say that they are desperate to have a group of humans that they have a deeper connection with, patients and clinicians alike, who they can also process this with. We've got to move away, not just in our national conversations, but in our local leadership conversations. We need to move away from that finger pointing and transactional quality and engage these leaders as humans and figure out how to develop bidirectional empathy with them just as much as between patient and clinician. So that triad of relationships feels so important to us now more than ever, emerging from a time that's been isolating and trying for so many people. So in addition to COVID recovery for patients and clinicians, as well as some virtual programming, we're also designing a more intensive approach to support patients, clinicians, and the local leadership to come together in these smaller groups. So we're really excited about that. I should also say a lot of people ask us immediately, how much does this cost? This is a grant-funded program. We're really fortunate to have funding support from the Morris Singer Foundation to do this. So there isn't a cost to doing this. Fortunately, thanks to the Morris Singer Foundation. And we're just excited about how to really be part of supporting the recovery of our healthcare system the minute we start to gain some capacity.
So I'm really appreciating hearing all of this. One of the things that I've watched happen, I've been in healthcare systems, in hospitals, in academic medical centers, and I'm a hybrid person. I'm neither. I am a clinician as a social worker, but I'm not a physician. I'm certainly not a nurse. I am from time to time a patient. And occasionally in my career, I've been a hospital administrator or a healthcare administrator. And one of the things, and you touched on it just a moment ago, that I think is really important, is there has been a divide between administrators and especially the physicians. There's been gaming on both sides. There's been mistrust. There's been finger pointing. There's been joke telling. And I think that I'm happy to hear that you're thinking about addressing that issue, because except in independent practices, the issue of administrators and particularly physicians working together in a truly collaborative, relationship-based kind of way, I think is really important. Do you want to comment on that?
I really do, because we're seeing in the media a lot of clinician voices. I don't know if it's a lot, but we have seen instances of clinicians who are really angry with leaders. And we've seen clinicians being fired for speaking out, so might be an indication that the leader was angry with the clinician. I'm deeply worried about that dynamic. And I believe that we need a forum for a very different kind of conversation. I mean, it's not totally unlike a very unhappy marriage where, I'd speak as to you as a social worker, where, the husband and the wife are blaming and shaming each other and assigning intentionality. But when they get into therapy and they like sit down and have that deeper conversation and really begin to understand what are the fundamental human needs that are underpinning the actions and the behaviors, how, what emotions point to, whether those human needs to feel respected, heard, understood, to engage in a new way, whether those are happening, that's the science that underpins the third conversation. Again, not that it's a panacea, but I think it's helped us understand that the conversations that have happened between clinicians and healthcare leaders often don't go deep. They don't get deep enough to really understand the humanity behind it, the choices, the difficult trade-offs, all of the moral injury that both sides experience. And so our hope is that we can be some small part of facilitating moral leadership, really, but bringing them together in a new way that fosters some healing, but also allows them to just understand each other from a fundamentally different perspective than they're accustomed to. So this, third conversation is definitely not for everyone. Definitely countercultural. It's definitely pretty antithetical to the way we've led healthcare for many years. That's not true for all leaders. And we were fortunate to interview a number of them who have that deep humanity ingrained in the way that they lead, and they lead through empathy. And that really is important. And so we're hoping that we can, learn from working with those places that will be inclined to take that adventure with us and really begin to repair and reconnect in a way that is so critical, particularly post-COVID.
I absolutely agree with you. Could you speak to the long-term impact of your work? What are you hoping, looking down the pathway here? What are you hoping can happen?
My deepest hope is that we will learn from these communities and from the front lines about how to really change the conversation at the national level, so that all of the key players, leaders, policymakers, employers and purchasers, have a seat at the table alongside patients and families, clinicians of all stripes, staff in the healthcare system. It's past time for a new conversation that is not just about the technical and the structural, the what and the how of healthcare, but really is fundamentally more relational, not more relational as a healthcare system, but also the conversation and the path for getting there has to be more relational. If finding a forward-looking solution was simply about ideas or knowledge or lobbying power, we would have done it by now. There's no shortage of any of that. So it's really time for a reinvention of how we work together as well as what we do. And that's what I hope that their conversation can really begin to contribute to, because I think that communities offer really essential insights and are a fertile ground for reweaving the human connection of healthcare and using that reweaving as a springboard for new, truly innovative approaches and solutions. So I'm really hoping that for third conversation, we can, number one, help facilitate an immediate reweaving and recovery post-COVID. Number two, that these communities will shed major light and create new pathways forward based on having rewoven human connection into their systems. They can create a lighted pathway for what we need to do as a country.
Well, all I want to say, Christine, is I want to do, and the FMEC wants to do whatever we can to help support this. I think this is brilliant work and important work, and I think there's incredible opportunity. I'm glad to hear that you're already thinking about the healing that in the reconnecting that needs to happen in this post-COVID, in a post-COVID United States. So I commend you for the work that you're doing.
Thank you, Larry. I'll leave you with one quote from a patient. This was our very first pilot of third conversation. And at the end of the night, we asked them to sort of step out of the pilot itself and kind of go to the balcony, if you will, look down on the conversation of the night and tell us what they thought. And one of the patients looked at us and he said, you know, this is what we've needed for a long time. Everything that gets fixed in life starts with relationships, and that's where we have to go. And I just loved that. So thank you for having me.
I love it too, Christine. Thank you very much. I've been talking with Christine Bechtel, who is a patient advocate and co-founder of X for Health, and a purpose-driven organization on a mission to make healthcare better for all people. And I think you're well out of the gate moving forward. And as I said, the FMEC is happy to support. I do have one question for you. Would you mind if I put your email address when we render this material and put it out there, so if people want to talk with you or connect with you afterwards, they're able to reach you? Would that be okay?
Sure. And the website is www.thirdconversation.org. And we also have an online community. We have two of them, actually. One is on a platform called Mighty Networks, and that is a space that is open to anyone, but not as easy to find as something like Facebook. And that's where patients and clinicians can come together and talk and think about some of the issues we've been talking about today. And that email address or that website is join.thirdconversation.org. I can give those to you as well. And then we also have a Facebook group for patients and providers supporting each other during this time of COVID.
Fantastic. And just to clarify for people, Third Conversation is the number 3 followed by RD in the word conversation, correct?
You got it. Thank you, Larry.
Okay, good. Christine, thank you very much.
Thank you, Larry.
Take care.
Bye.